And then start webinar. And then just see if any attendees come in. All right. If they come in, they come in. But just to get started, welcome everyone to an episode of 𝘾𝙊𝙉𝙑𝙍𝙍𝙍. This episode, we are here with we are joined by Dr. Philip McClure, who is the Assistant Director of the International Center for Limb Lengthening in Baltimore, Maryland. I lost my notes, but thank you for joining us. Can you tell us sort of a little bit about, your practice and what you do at the ICLL, which is short for International Center for Limb Lengthening?
Sure. Thanks for having me on, Chandler. I appreciate it, and for all the work you've done helping patients with achondroplasia and other rare diseases find the best and latest information. So I'm an orthopedic surgeon. I did fellowship training in trauma, pediatric and adult trauma, pediatric orthopedist, and limb deformity. I worked briefly at the University of Utah. It was a fantastic institution. And then I came back to work with Dr. 𝘾𝙊𝙉𝙍𝙑𝙀𝙀 and Dr. Standard at the ICLL, and to take on the, sort of the assistant director role. My entry into orthopedics is sort of hard to know exactly what the primary driver was, but as a kid, I worked at a camp for children with disabilities, several of whom had lots of orthopedic intervention and would get better every year. And I thought that was pretty unbelievable. When I look back at my application to medical school, I actually wrote about some of the kids I worked with at that camp and the difference that orthopedics made for them. I have a family member who has transverse limb deficiencies and has orthopedic needs. And I was a physics major in college. So, in medical school, everything sort of came together and I went into orthopedics. I'm very happy about it. I focus almost exclusively on limb deformity from various causes, post-traumatic, post-infectious, congenital, metabolic bone disease, etc. Skeletal dysplasia, of course.
Very cool. Sorry. Can you sort of tell us more about the ICLL and what a family, of a child with, or a patient of any age really with achondroplasia, what they may expect if they're coming to, visit you or the practice in general and are seeking information either about limb alignment or limb lengthening, and how do you best determine the treatment plan for a patient who has achondroplasia?
So we have patients from all over, traveling far and wide for achondroplasia and other needs to the ICLL. Depending on which site they come to, we have access to the latest and greatest in standing low-dose radiation, low-dose X-ray, and the EOS Edge machine that we have at the hospital. So if a patient comes there, they typically would get in that machine to get views of the legs from the front and the sides to make sure that their alignment is acceptable, and sets them up for long-term success and reduce any risk of instability or arthritis down the line. Even though arthritis and achondroplasia is a little bit unclear how much risk you have for that. If you have bow legs, for example, certainly there are other side effects of bow legs that can be quite problematic with instability in the knees and discomfort. So we have low-dose X-ray scanning. We have a gait lab that we use if people have particularly difficult gait issues that need to be addressed. And we have endocrinology service who helps us with any sort of metabolic treatment or medical treatment for achondroplasia. Obviously, everybody knows about vosoritide or Voxzogo. There's a couple others working their way through the pipeline that I think will also be part of a decision in treatment. And we've decided at our institution to involve the medical experts because we're the surgical experts. And we want to respect their ability to be subspecialized within their own field. So our endocrinologist drives the boat on any medical treatment at the ICLL, but we can, obviously route patients to them. Actually, just had a patient coming from international hoping to get on vosoritide, and that's exceedingly difficult outside of the United States right now. Hopefully there'll be some improvement as time goes on with approval in other countries as well.
Mm-hmm. I asked about, limb alignment and limb lengthening. Can you sort of explain the difference between the two? Because I think sometimes people think, can I go in for just limb alignment, not do lengthening, or, vice versa or whatever. So just so, people know, can you sort of explain like what is limb alignment versus what is limb lengthening?
Sure. They are, they're very different, but they are tied together. Not everybody who even gets a, limb lengthening type surgery is really going for any extra, addition to their stature. Excuse me. In achondroplasia, bow legs or 𝘾𝙊𝙉𝙉𝙑𝙀𝙍 is very common, actually at the knee and the ankle. And there are patients who have symptoms related to that or have concerns regarding future symptoms related to that. And basically limb alignment is making sure that the knee is centered between the hip and the ankle, so that your mechanical forces going down through your leg are centered through your knee joint, sort of right behind the patella, so that the forces on the medial and lateral sides of your knee are as they should be, the way that our bodies were designed to handle it. With significant bowing, you can put 100% of your force on the medial side of your knee, and it's not made for that. And that puts you at risk, in the greater population, puts you at risk for accelerated arthritis. And it's certainly something that can happen in achondroplasia, although because of the overall incidence, I'm not sure we understand the risk of arthritis in achondroplasia as well as we do for people without achondroplasia. Although, suffice it to say, there are definitely people with achondroplasia who have a malalignment and do end up with arthritis. So if you have symptoms that would be related to arthritis, medial joint pain, and bow legs, I wouldn't advise a patient who has symptomatic malalignment and achondroplasia to say, well, people with achondroplasia don't get arthritis, because that's not true, especially not on an individual basis.
Mm-hmm. I would say the next two questions actually sort of do go together. But the first one was, when correcting bowing for achondroplasia, how and when is it determined to use internal 8 plates or external fixators? And then the next one was, when it comes to lengthening, how do you determine internal versus external fixators? So I guess we can answer the first one, or whatever best, you want to answer.
Well, let's start with the first one, because that's an important topic and something that, certainly you don't have to travel across the country to get treatment with 8 plates in order to correct 𝘾𝙊𝙉𝙉𝙗. 𝘾𝙊𝙉𝙉𝙗 is nearly universal in 2-year-olds with or without achondroplasia. And so we're generally not treating toddlers with bowing unless it's sort of outlandish. Blount's disease would be one, or severe physiologic 𝘾𝙊𝙉𝙗 that was starting to affect the stability of the knee. But once you get to age 3 or 4, typically your mechanical alignment should be straight. Unfortunately, my skeleton's giving as a side profile, so I can't use them as an example here. But the knee should be right in between the hip and the ankle, with the axis going right down the middle by age 6 or 7. At 3 or 4, if a patient still has a lot of bowing, it would be a wise consideration to put an 8 plate, or in the generic term, a tension band plate. There's multiple companies that make them to help use the growth that remains to help to straighten out the limb. It doesn't seem to cost any length to tether the growth with growth modulation. And in achondroplasia, what we found is if you start early, you have pretty good results. You can get a new mechanical axis. If you start late, when we would usually start at age 9, 10, 11, 12, often it's too late in achondroplasia because the rate of growth per year isn't high enough to generate the change that you need to get the limb straight again. How that will be affected by the medical treatments, I think, is anybody's guess. We think if the growth rate goes up and you've got an additional centimeter and a half per year, that should improve the outcomes of growth modulation at a later age. At a later age, what we do is, if we think we might be too late, then we use a screw that goes across the physis instead of a plate that goes outside the physis. There's recent literature that suggests the screws work faster. I personally wouldn't use a screw in someone who is under age 10, typically, unless I was worried they were running out of time to get straight, because you're directly crossing the growth plate with the screw. So that's the sort of the growth modulation talk. It is important for patients and surgeons to know that the bowing can come from the femur or the tibia. There's a phenomenon called the oblique joint line that fortunately our sports colleagues have caught on to and started to do some cadaveric research on how it would affect the ACL and potential wear and tear. And more than 5 or so degrees of an obliquity of your joint line to the floor increases shear stress on the cartilage and might make your long-term outcome worse, even though your axis is straight. A straight axis through an oblique joint still creates abnormal forces. So it's important to know that femur or tibia, and so in very young kids, we actually put dye in the joint while the patients are asleep and double check everything. Hey, are we supposed to be treating femur or tibia? Because it can be either, which is a little bit sneaky, because historically they said bowing bow legs comes from the tibia and knock knees comes from the femur, but it's really not that clean.
And then the next one was, when it does come to lengthening, obviously the internal nail has been the latest and greatest thing for the past few years, but external is still a thing. How do you determine when you use internal versus external lengthening devices?
Sure. So we'll let's start talking about the tibias first, below the knee. For length below the knee, the external fixator still remains the sort of gold standard. People have tried putting nails outside the bone. The reason we don't put a rod through the tibia or into the tibia in a young person, meaning a girl below 14, a boy below 16, is that you have to cross the growth plate in order to get into the tibia. And especially if you're trying to add length, it doesn't make any sense to drill out part of the growth plate to put in the device that's going to help you add length. Mm-hmm. Although, in the trauma world, they have, internal fixation is preferred for tibia fractures. And there's some data that, you can push that limit by about 2 years without affecting growth. For us at the ICLL, it just feels a little bit illogical to go through the growth plate that you're hoping to try to supplement with growth. So we use external fixators until the growth plates are closed. There was briefly an external plate that we were one of the initial centers to try. Unfortunately, that's now back to the drawing board trying to improve. And there's really not enough room in most people's lower legs, tibias below the knee, to put the rod next to the tibia. So that's something that we'll talk about for the femur, the extramedullary treatment to try to gain length without the rod being inside the bone. So other than future growth potential, young kids with an open growth plate, when do you use a fixator versus an internal nail? And this depends a little bit on the patient's underlying sort of background stature. Within achondroplasia, just like the general population, there's a bell curve of adult height and of bone lengths. There are some people where even when they're done growing, the tibial rod will not fit, the shortest tibial rod. And so they're going to get an external fixator, whether they wait or not. Fortunately, in the tibia, the external fixator is not so bad. I mean, I don't think anyone's ever asked me to leave it on longer, but it's not as problematic as the external fixator on the femur. So we don't.
I attested that.
Yeah, you agree, Chandler? I feel a little silly saying that with you sitting there having been through both.
No, I totally,
both,
yeah, no, I totally agree. A tibia X6 over femur any day, definitely.
Yeah, I think you have nearly 100% agreement from our patients on that. But the tibia X-fix is here to stay for at least the foreseeable future for lengthening and achondroplasia. Another advantage of it is it gives us very precise control of alignment of the tibia. So if you don't like it, you're 1 degree off, you can make it perfect. And for me, as a math and physics guy, I really like the idea of it being perfect. But part of the reason I try to make everything perfect is biology is sort of a much sloppier science than physics and mathematics. If you think it's perfect, it may not be. But if you're on a bell curve, and see if I can make my hands do a bell curve, and you think you're right in the middle of it, but you're a little bit off to the side, you're still well in acceptable range. If you think you're barely acceptable, to me, you might be in trouble. And so that's one of the nice things about the X-fix is you can just make a little tweak and get the alignment just right. On the femur side, it's a little bit of a different conversation. Most patients, although not all, with achondroplasia will eventually have long enough femurs from the trochanter to the distal femur to fit a rod in. But sometimes that's not possible, and we're looking at either trying to sneak an extramedullary precise next to the bone so that we can add some length and then get an internal precise rod in later. The external fixator we really try to avoid on the femur if possible. So if we had a 10 or 12-year-old who would eventually have enough room in their femur for a rod, I would usually try to get that family and that patient to wait, because the femur X-fix, even though it's dependable and does work quite nicely, it's difficult. It's a much harder stress on families to get through, and there's more scarring, and that's an important thing to consider as well. So the femur X-fix, we're really hoping doesn't stick around. The tibial X-fix, at least for now, we're kind of okay with, especially in light of the alternatives.
I did have another question, or I have a few, that kind of followed up with that, but we did just get one question from a mom. I am from, or a parent. I am from Canada, and my daughter has achondroplasia. She is 3.5 and has a lot of bowing. Her bone health doctors in Toronto don't recommend bowing before 5 years for children with achondroplasia. And as I heard Dr. Phil suggesting to correct the bowing before 5, I'm a bit puzzled. She's asking, what is your recommendation that is based on recent research?
Sure. So it depends on how bad it is. If it's just a little bit of bowing, sort of within a physiologic range, I think it's totally reasonable to watch and see, is this going to get better on its own? The natural curve for alignment in children is that they're maximally bowed at age 2. They're typically knock-kneed by 4, and then adult, straight down the line by 7 or 8. Achondroplasia, I'm not sure we know exactly whether it follows those rules, but for me, if a kid is not headed towards normal alignment by 3 or 4, since that would be the typical curve, I would consider doing the growth modulation then. We do know that if you wait longer, especially with severe bowing, you sometimes miss the opportunity to get it fully straight. And so it really depends. It does come down patient to patient. And, resources and, other health concerns can sometimes be challenging for getting into the operating room. But for a healthy kid, without, other things stopping them from having it, if they were progressively bow-legged at 4, I would put the tension band plate in. But you have to understand, as a physician, family member, patient, even little surgery is still surgery. So you don't want to go into it willy-nilly, but you also don't want to do a surgery that has a lower risk of success because you waited past the window. In kids without skeletal dysplasia, realistically, I'm trying to pose the question to myself. If I had a 2-year-old who was getting progressively worse through age 3, with or without achondroplasia, I would consider growth modulation, because they're not following the curve that they should be following. Without achondroplasia, though, we'd be looking for vitamin D deficiency, some other metabolic bone disease, because we don't want to miss a chance to take better care of the patient as a whole and only take care of the legs. And it's one of the reasons I went into peds ortho, is that we're a little more real doctors than some of our orthopedic colleagues.
So my question that I was going to ask before this one was actually about physical therapy, but since we were originally talking kind of about the internal and externals, one of the questions is for achondroplasia, will internal lengthening ever be possible? And for arm lengthening, will using internals ever be possible for arm lengthening for achondroplasia? There we go.
Yeah, I think in the future it will. Right now, in some cases it is, again, depending on the anatomic length, varying person to person. What's not possible is to get usually the length that you're trying to get internally with just one surgery. So the rod is pretty fantastic. It's made amazing differences in the lower extremity. Chandler, we'll let you talk about your experience, because you also did this, although you did not have internal humerus, I don't think.
No.
So you can't say both sides. But the rods that fit into the humerus used to only go 3. Now they can go 5. But there aren't very many humeri out there, even outside of achondroplasia, who can fit the rods in that would go 8 centimeters. And with the external fixators, we're often aiming for 8 to 10 in order to get people to clear their head and be able to take care of themselves in the bathroom. So it's even before we start talking about going through the rotator cuff, which is one of the more important structures in your upper extremity to get the rod in. I hesitate to think that the rod is going to overtake the external fixator in the upper extremity anytime soon, because there are practical limits to how long they can get a short rod to go. Once you can say, well, we can get you the same length internal versus external, then I think it's going to be a much more open debate. And I do think we'll get there. I'm sure there's companies chasing at the tail of Nuvasive and Precise, trying to get smaller and stronger and the ability to go longer. But what would you say, to someone asking that question who's thinking about upper extremity and the impact of therapy? I mean, you can see your pin scars, but what about therapy for the upper extremity versus the lower?
Well, the therapy for the upper is very easy. I personally know at least, I think, 2 or 3 patients' families with achondroplasia who went ahead with, doing the internals and the arms, but, they had to be like, fit well for it. And they did not get I lengthened my arms 4 inches. They were only, I think, able to do 2 inches. And then they were going to go back and kind of do it all over again. And then also knowing that arms kind of take longer than legs, at least it did for me, since there's no weight bearing for the bone growth in the consolidation phase. So I, when people ask about it, I'm like, just do the external. I mean, yes, they're annoying when you have them on and whatever, but you do get used to them. And then also, you were talking about how, the rod goes through the rotator cuff. And it, just kind of dive into my personal experience. For anyone who like watches this, when I had my arms lengthened, it was in January of 2012 was my surgery, and I was moving into the college dorm that August, and I every appointment told Dr. Standard I'm not going to school with these on, and he was very, he made sure that wasn't going to happen. But when I had my fixators removed, the bone, he was confident and the bone was great and everything, but just, for precautionary measures, he did put the brush rods in through in my arms. And that because I had fixator removal for legs, and that was whatever, I was in pain after my arm fixator removal because of the rods going through my shoulders. And like, that's what, they were saying. I'm like, that's like, I personally, I felt, I think for a good, like 2 days, I kind of felt like I'd been run over by a truck. Cause I was just like, but I mean, I was fine after the fact, but, I think about that when they, say the rod going through the rotator cuff and everything. I'm like, that really was not like, that was so just the rush, when I just had the little rush rods for my fixator removals, I'm like, that was discomfort. But I mean, again, I was fine, a few days later, but just I was not expecting that at removal, because typically when you have removal, it's easy peasy. At least
in my rush rods are actually, they're even lower profile than the main rod. And so when we talk about putting a rod, a lengthening rod or a trauma rod into the humerus, a lot of the limb deformity world is following the trauma world in various ways, but it's very uncommon to put a rod into the humerus for fracture because of the rotator cuff. And it's different than the knee. The knee, there's a way to get into the tibia without really going through the joint. And you can actually even put it next to the tendon instead of through the tendon. For the shoulder, you either have to go through the joint surface itself or through the rotator cuff insertion, which we've debated back and forth on which one of those is better than the other. And often that's because neither one is really so great. And so the most important thing, I think, with the rod and the humerus is your end result is either going to require 2 to 3 surgeries before the rod comes out to get the same length, or you're just not going to get as much length, because the rods will go usually 5 centimeters at a run. We do reactivate rods or retelescope them or let them sleep and wake them back up again. But that's a little bit frowned upon by the company. They can't really warranty that it's going to do what it's supposed to do the second time. So the humerus with the internal is very doable, but I think when you take the overall risks and benefits, and we haven't really talked about the risk to the spine of going to sleep and being, flat on a table without the ability to have, sort of protective reflexes. Another trip to the operating room to go to sleep and wake up just to keep 4 pins out of your arm. I think most patients, not all, most patients would say once they get all the information, the external fixture sounds okay. I'd really, I don't want 5 centimeters. I want 10 or 12. I don't want 2 or 3 surgeries. But it's a conversation, and that's one of the things I like best about limb deformity as a practice is that you sort of get to be a real doctor. It's not just my knee hurts. Okay, here's an injection. You get to really go through the ups and downs of all the treatment methods and try to help people find what's best for them. And sometimes what's best for them after getting all the information, they say, I guess I'm fine like I am. Can I still do this later? And that's a very common question. Or, when do I, or when does my daughter, when does my son miss the window to do limb lengthening? And biologically, healing potential wise, there doesn't seem to really be a window that closes, which is very comforting for families to hear, because sometimes we get 4-year-olds, parents who are very concerned that they're starting to lag behind their peers in various ways, or they just, you can now really see that they're shorter stature. When does this window close? And other than the fact that life gets more complicated, as you know, Chandler, you get into college and then you get a job, and it's harder and harder to set aside the time needed for a proper recovery from limb lengthening. You can still heal, well into your 20s. We actually have a paper. No, I don't think there's anybody with skeletal dysplasia in it, but lengthening in the elderly patient, I think it's for 60 or 65. We have a series of patients in their 60s or older who healed from lengthening. So it's it's a important conversation to have, and sometimes just knowing that the window doesn't close is all the patients really wanted to hear, and that's okay. Sometimes that's an hour-and-a-half conversation, but that's okay too.
And like with my actually a few episodes back, we talked with Dr. McKenzie, and he brought up my own experience. But I remember people, talking like as you age, asking about the healing. And I do remember my second lengthening, I think I healed slower than with the first, but they were saying my being female and my age kind of like played into that. Cause I guess, women in their 20s, whatever, they start to like, however, I feel like I should know all of that. I don't, but I remember being so annoyed because I was kind of lengthening at the same time, with a friend who he had hypo, but we were around the same age, and we literally had our surgeries kind of like very close together, and he would go to clinic and his bones were like solid and mine were just like they were getting there. But I remember I would get so annoyed because we would have clinics a lot on the same day. And it was a joke, but still, I remember just being like, but that was always my thing.
Well, there are second lengthenings often heal slower. Depending on how far apart they are, that can play into it too. Overall, general health, stress, all that.
I was probably stressed. I don't remember, but but it was also only 2.5 years after my first one. So I definitely think that obviously played a role in that. But speaking, I guess, of and I think we may have actually kind of said this, and we know it depends, but what is the best age, I guess, if a family or, patient is actually going to start thinking about pursuing lengthening? And I know the ICLL has a great, kind of play-by-play on their site that we'll be sure to share when we post this. But, what is the best age, or I guess typical, age mapping of when a child with achondroplasia is sort of going to start the lengthening process?
Yeah, so on our website, I think we have 2 sort of different pathways and a couple different options. And of course, as you said, every patient can choose differently. But usually, for me, it's not necessarily a number. It's more of a mindset. And so if the child is the one looking for the change, that's a positive. If the kid's kind of like, I don't care at all about my stature and I don't have any issues, and the parents are worried, and then a lot of times it's like, well, let's just see, because there's lots of people who never do anything and they're fine. There's a family in Salt Lake City who runs a very successful bakery, never did anything, totally fine. And so unless the patient's looking for the change, I really, that often becomes a long conversation with the family on, look, that this is going to be okay. If they're not looking for a change, don't force this change, because it's a lot of work, and there's risk involved. So if the patient's not driving it, then they're not ready. I find it's usually 12 or later, where the patients are really driving that decision, if ever. I've had families where one child drove it and wanted it, and the other child is like, I'm fine, I don't need anything. And that's totally acceptable and completely reasonable. So for me, I would say I'm rarely thinking about surgery before age 12. Mm-hmm. You also want to make sure that they can communicate clearly enough, and that's not an age; it's more of a behavioral thing as well, so that you can really screen for any neurologic symptoms from spinal stenosis or foramen magnum stenosis, because those can be very important things to monitor. And if you have no idea, it's a little harder to interpret the monitoring that we have while the patient's asleep. If you get numbness in your legs from sleeping in a certain position, and we were able to have that conversation ahead of time, we don't put you in that position in the operating room. We try to put you in a different position. Mm-hmm. And if you say, well, I don't know how I sleep, but sometimes I wake up and my legs are asleep, we watch the monitoring. And if it starts to go funny, it's how maybe we better change the position their body's in, because they do have this thing that happens to them. Or fatigue with walks, that's another one that's difficult. And it would be really helpful, I think, to get a panel of us in a room, McKenzie and some of the other very experienced skeletal dysplasia physicians. And what do we make of fatigue with long walks? I mean, I get fatigue with long walks. Like, does that mean I have stenosis? It might. And when a 10-year-old kid says, well, my legs get tired on long walks, but all I have to do is slow down and it goes away, or I have to stop and I have to squat. Well, that's a little scarier as far as a symptom of stenosis. So, we get into conversations about other medical or anatomic manifestations of achondroplasia that might affect your risk profile for lengthening. One of the trickiest conversations that I just had this week, actually, to really try to figure out what the best thing to do for a family is when they would like to undergo lengthening, they have some questionable symptoms of stenosis, and the spine surgeons are suggesting that the only way to proceed would be to have a fusion. Because once you fuse a spine, you can't unfuse a spine, and the loss of motion can be significant. And if the only reason you're doing it is because you want to have lengthening, then you have to really reorganize your brain, at least in my mind, to say, well, all the risks of spinal surgery are therefore risks of lengthening, because if you wouldn't be doing it otherwise, then it's the lengthening that's making you taking on that risk. And that's a tough decision to make. Luckily, we have folks like McKenzie who can help guide people through their spine management. And I'm glad to hear he's been here. He's a pretty phenomenal guy.
Yeah, I think he's here, but it was in our last episode. He is entering retirement, and so I know a lot of people are sad to see that, but his son, I know, is going to be great and what have you. But yeah, McKenzie is fabulous. So, and I know just since we're kind of talking about the spine, how, and this wasn't a question, that I had initially, but just it kind of reminded me how, how does, because I know like when I had lengthening, a lot of people ask, how does, I guess, deformity correction and lengthening help with the lower spine in achondroplasia? Because it did for me help, with whatever Dr. Standard did to help take the lower pressure off my spine. I just figured since we're here, that would be a good question to kind of go over, or a good topic to go over.
Yeah, so it does seem to help. And what's interesting is there's a couple reasons it might help, and we don't really know which one is the real driver. So we can purposely take the femurs and extend them, which Dr. Standard will often do, with the theory being that if you extend the hips, then it has an effect on the lower back to take that hyperlordosis out. There's other people who say, well, just by making the femur longer, you're going to tighten the hamstrings. And in achondroplasia, there, maybe redundant's not really the word, but perhaps loose. And by adding length to the femur, the hamstrings retighten, that pulls on your pelvis and takes that out anyway. So we are trying to get a series of patients that we either have or have not extended the femurs as part of the lengthening to see what happened to the pelvis. Unfortunately, the EOS machine that just now exists from 2 or 3 years ago, the EOS Edge, we haven't had that forever. And its predecessor, the regular EOS, didn't exist forever. And so there's a lot of data that's kind of lost, I guess, even though it's hard to say it was lost when you never had it in the first place. But we don't have necessarily long, extremity and lower spine laterals of every patient who's been lengthened to look at, did their lumbar lordosis change? And that is that's a good question to ask, because in theory, if you can reduce that hyperlordosis, you can maybe have some impact on the stenosis. But I would be sort of cautious about saying in general that your spine improves with lengthening.
Right.
Because the general mantra of lengthening is that everything gets worse with lengthening but length. Although there does seem to be in achondroplasia this effect of taking the some of the lordosis out by some mechanism that we don't yet really have fully defined, although there's a couple different explanations that maybe it's a positive side effect.
And then the next one that I had, that was kind of really the last one. No, obviously, everything is changing, and like just mentioning the EOS. One question I get a lot is like how lengthening has changed from the 80s, 90s. Even when I had it in 2010, I did not have this EOS machine, which I know my mom probably wishes would have been available because the less radiation exposure and whatnot. So that that's always changing. Obviously, treatment for achondroplasia has been changing over the course of the past decade, really. And so my next one was, obviously the big thing right now is Voxzogo and other therapies that are coming into the development. And so a question that I personally get a lot, and then I'm sure you get a lot, and other professionals get a lot, is, or physicians is, can taking these therapies, can patients who are going through lengthening take, these therapies in addition while going through lengthening? Do they need to do it before? Do they need to do it after? Just because that's really a question that I constantly get. And as well as so many people get. So just kind of like the combination of treatment, if that's even a thing.
Well, I think the driver of that question, or sort of the etiology of that question, is that during the trials, you were not allowed to have lengthening if you were in the trial. To my knowledge, that wasn't really a concern about side effects or risk of surgery. It was really that their primary endpoint was height velocity, because it's so easy to measure. And obviously, if you have lengthening, it's going to screw up the data. So that, I think, is the root of that question. Although now that that's a standard question, it's a standard question, of course. And yeah, you can go ahead and have lengthening despite medical treatment. One of the interesting things that is really kind of brand new, at least in the US from an insurance standpoint, is we've had a slight uptick in denials for surgical lengthening.
I've thought about that. That's been on my radar when people bring that up. And my thing is, like, if insurance companies note that they've taken Voxzogo, are they then going to approve or deny lengthening? I have thought about that so much.
Well, I hadn't really entered to that standpoint of like,
oh, sorry. I thought, sorry to interrupt you.
No,
sorry.
It wasn't a patient who'd been on it. It's just that I think, there's only a certain amount of resources in the world, even in the United States. And when insurance companies are looking at perhaps setting aside hundreds of thousands of dollars a year for a decade for every patient with achondroplasia, there's just not going to be the money for lengthening. And I think I would really like to see and have very clear data on the implications of medical treatment on the things that surgery can't fix or can't fix without major trade-offs like stenosis, foramen magnum, and the spine, and some of the other manifestations that there aren't real options for. Because if you're taking several $100,000 a year drug for 10 years, that's not that limb lengthening is cheap, but that's a lot more than limb lengthening. And I don't know what's going to happen in the United States, but I do think that maybe it's a blip for us, but we've gotten a few denials and that have turned into just stone cold denials. Like, I don't care what this patient's symptoms are, we're not paying for it. And that never happened before, this last year. So, it's going to be a interesting couple of years, and it's going to make for some very tough conversations, because I don't know, and I don't think anybody knows which really has the better risk profile. So, but here we are, happy to talk about it.
I always say lengthening is always going to be there, and we know you can watch it as it happens, you can monitor it, and see it physically happening. But it is exciting to have these treatments, options available. But just like personally, people always ask me, oh, would you have rather done one or the other? And I'm like, I don't know, just because it wasn't available to me when I was younger. And I think my parents too have said, my mom has said, I probably maybe would not have you on the treatments if it was in the stage that it is now, just since there's not all this, data and everything. I probably just wouldn't want you to have been like a guinea pig in a trial. But, with orthopedic surgery, I think Dr. 𝘾𝙊𝙉𝙍𝙍𝙍 once referred to you guys as, you're the carpenters. And so it's like, you can watch it, you can see it happen. You can if something comes up, you know how to tweak it right away. Whereas, when you're taking a medicine, you're like, so much more goes into play with that. And so, but
yeah, I'm hopeful that the costs come down, because if the costs come down for the medication, then it's more available worldwide. It's more available within the country, and then financially, we're not put in a situation where only one option becomes available because of the overhead of treatment. But I think the medical treatments will improve, surgical treatments will improve. It's an exciting time to be in the world, but that also makes it a little bit of a scary time as you try to make the right decision, because it's when you're talking about yourself or your family member or your own patient one-on-one, it's a lot more real than just sort of theorizing about it on the internet.
Well, I think, that was really kind of the end of it, or the last question I had. If anybody who's on has any more questions, feel free to type them in. Other than that, thank you for joining us. We, of course, would love to have you back, maybe have the whole team back, or if you and Dr. McKenzie, ever wanted to do one together. We've been brainstorming doing maybe collaborative episodes with different physicians or whoever. But I just want to say, on behalf of Growing Stronger, thank you for joining us for a conversation. And we appreciate your time and everything. Oh, wait, did we just get another?
Well, thank you, Chandler. It looks like one popped up there.
It's just a thank you, but thank you for joining us, to our attendees, and then thank you, Dr. McClure.
Well, thank you, Chandler. I appreciate it, and thanks for everything you've done for these patients. And feel free to share my email address if anybody wants me to look at X-rays or give them advice. Happy to do so.
Will do. Thank you.
Thank you.
Bye.
Bye.